Somehow I got it muted. Sorry. Hopefully that wasn't long. Okay, so we're gonna look at emphysema. I'm gonna finish obstructive lung disorders, I think, and it's again related to destruction in the alveoli walls, the velar walls, without any obvious fibrosis present. And what happens is that the alveoli lose their elastic recoil in emphysema, and it's really a gas exchange issue with the alveoli that we're looking at with emphysema. So some of the pathophysiology here, it's still we get this immune system response, but what happens is that these and neutrophils release these enzymes to try to deal with issues and these what happens is the elastin fibers that are found that keep the alveoli open are destroyed by destructive enzyme proteins, and basically that the cigarette smoke sort of is involved here as well. I'm sorry. So yes, when those dead, I said that kind of wrong, but so anyway, think of this recoiling and stiffened lungs that are kind of off there. And again, cigarette smoke is involved. All righty, let's go on. We're going to go into restrictive lung disorders. All right, looking at the restrictive lung disorders or diseases where we have a reduction in large volume, and so we have a problem inhaling air. Bronchiolitis is one of the inflammatory um, disorders where there's an obstruction of the small airways, and most common in children, and it occurs in adults also with acute bronchitis or viral infection or inhalation. So just keep that in mind that that will reduce the ability to inhale air, restrict it, I should say. Pulmonary fibrosis, this is one that you might see. It's sometimes idiopathic, but the lungs are sort of scarred or become fibrous and they don't work real well. They get thick, the tissue between and around the alveoli, the air sacs in your lungs, and it makes it, again, difficult for oxygen to pass into your bloodstream. Think of the VQ there. It can be secondary to infections and like tuberculosis, and chronic inflammation can cause this. And I've seen this where it just it constantly is creating a need to try to fix an irritant or something, and so it actually ends up depositing immune molecules, or I would say kind of like crystalline filtrates into the lungs, which is kind of what this is getting at here. But you don't have to know everything about this. What I just said was enough. All right, and so all of this is another way of looking at, let me see if I can get this so I can, whoops, see it a little bit better up here. Um, but yeah, look at the agents up here. I'm sorry, I can't read them all, will lead to tissue injury, and that activates the immune system. And this is where we get that injury where we have the thickening of the lungs and the walls that cause reduced oxygen supply in the blood. And there's this perpetual shortness of breath. It can lead to hypoxia, hypertension, and heart failure. And yeah, so other things that can happen that can be a reduction in lung volume include aspiration, where you have fluid, or that's a dangerous situation where fluid or solid particles get into the lungs. Atelectasis, as we already talked about, which is a collapse of the lung or partial, or where the alveoli are deflated, and bronchiectasis, where we have the abnormal dilation of the bronchi. So we sort of talked about those as pathologies, but now those are things associated with the reduced inability to inhale, all right, or otherwise known as restrictive lung disease. Pulmonary edema is another one, and it's again related to heart failure and buildup of lungs. And think of normally the right side of the heart delivers blood to the oxygen, but when it fails, it can lead to edema in areas that are outside in the extremities. Hang on one second. Oops. I need to take a minute here. I have something going on I have to deal with. All right, let's get at this again and start with pulmonary edema. Sorry, I kind of got off track there with the right and the left-sided heart failure, but basically in pulmonary edema, you're not able to, you have excess fluid in your lungs. It accumulates in the airspace and the tissue of the lungs, impairing gas exchange and possibly leading to respiratory failure. But the buildup of the fluid is basically the inability of the heart or the fluid into imbalance between the forces that drive fluid into the alveoli and the mechanisms for its removal. So it just stays. And when your heart is impacted and it's unable to pump blood out of the pulmonary area, it results in that pressure and edema. That would be typically when the congestion occurs from kind of the left side because it's supposed to be going to your body and it ends up going backwards into the lungs. It builds up and it builds up like behind the valve and goes into the lung area. And it can elevate the pressure in a hypertensive crisis because of the increased load on the left ventricle, or kidney failure can be involved in this. But basically, the thing to remember here is that it's excessive water in the lungs as fluid accumulates. And it could also be a result, it's really common in different things, cancers, cancer treatments, injuries, aspiration, infection, inflammation. All of these things can reduce the ability to have those forces balanced that the alveoli can properly exchange gas and that the fluids can be managed, including heart failure, congestive heart failure. All right. Again, dealing with that pressure, the hydrostatic versus osmotic, and this is basically three things that we've already talked about with edema. But when you have a valvular dysfunction or coronary artery disease or left ventricular dysfunction, the fluids can, if the blood can't get pumped out, the congestion occurs in the opposite direction, so toward the lungs. And you have increased pulmonary capillary hydrostatic pressure in that case, can lead to pulmonary edema. You can also have injury to the capillary endothelium, and that could be caused by increased capillary permeability and a disruption of the surfactant that's involved in the alveoli. And then you get the movement of the fluid and the plasma from the capillaries to the interstitial space is disrupted and more accumulates, leads to pulmonary edema. And same consequently with blocked lymph vessels can the inability to remove that excess fluid from the interstitial space. Remember, your lymph system, in addition to being part of the immune system, it's a big drain. And so then you would get this accumulation of fluid in the interstitial space. All right, moving on to some chest disorders, chest wall disorders. Flailed chest, this is a video. Let me back out a minute. I think I made this, whoops, a video. I think you'll be able to play this, but it's really interesting to find a video and see how this works. And I thought this was a video, but maybe that's on the next page. But a flailed chest is a very life-threatening condition. It's when the rib cage breaks under extreme stress, usually trauma, and it becomes detached from the rest of the chest wall. This is my video, and I'd like to play it here, but for the sake of time, I won't. But you should. It shows. It's better to see it live than for me to explain it. But you get the flailed segment that's now detached moves in the opposite direction as the rest of the chest wall. So you get what's called paradoxical breathing. You should look at this video to see that. You can see a person that has had a chest injury, and they actually are showing it from the backside, but you can see this paradoxical breathing. It's very painful and it's not good, obviously, for the lungs, but you can see the flailed segment going in opposite directions. We're not going to play that I'll let you play that. So other pleural issues or chest wall or membrane issues. Your pleura, if you remember, is a large tissue that wraps around the outside of your lungs, and it can get swelling. But there's different issues here, but the one that is very common is called a pneumothorax, and then that's where you have a wall, or I'm sorry, a lung that has collapsed, and that's the most common cause. There's some other ones, and you can see here's the view where you have a lung that's collapsed, and it's a lot of the air fills the space and it looks dark on an X-ray. There's chest pain associated with this and shortness of breath. It's a medical emergency. This is when you would insert a chest tube to insert air back in there and fill that lung to keep it from to it's to make it uncollapsed, I guess I should say. And there's different kinds. I got a couple. You've probably heard maybe of a pneumothorax and a tension pneumothorax. They're basically the same issue. There's also a pneumothorax where it's blood that's causing the problem that's disturbing. It fills where the collapsed air was. But anyway, that you can see a normal pneumothorax and you can see the lung collapsed and then you see the air around it. In a tension pneumothorax, all that happens, but the lung is actually being compressed to the opposite side of the lung into there's a shift and it's causing pressure on the heart and mediastinal tissues in the opposite direction from the collapse. So those are two important pneumothoraxes to keep in mind. All right. Pleural effusion is again where you have the buildup of fluid in the pleural cavity and that the pleural space. It's kind of like cardiac tamponade, but think of it as the lung. In the fluid filled space that surrounds the lungs, it gets in excess. You can kind of see some images down here. But there's a couple, and I don't think I asked you questions about transitive effusions and exudative infusions, but they're just two different kinds and different causes. Transudative is more from extravascular fluid that's being pushed to the capillaries due to increased permeability. Think of this vasodilation and cytokine issues associated with this can be congestive heart failure, sorry, and cirrhosis. The exudative infusion leaking, you get some, it's related also to inflammation, but it's more associated with like pneumonia, cancers, and embolisms. All right, some infections, and we'll try to get through this. I know I'm going fast, but pneumonia is a very serious issue. There's a high mortality rate in elderlies. It can be caused by all types of pathogens, virus, bacterial, fungi, parasites, protozoans. I didn't know this. It's the sixth leading cause of death in the United States, and it's characterized by fevers, chills, and a productive cough. Most causes are viral for acute bronchitis. That's another respiratory tract infection. But it's self-limiting, meaning it usually takes care of itself, but it has a non-productive cough. Tuberculosis. This one isn't in your book, but I thought it was worth a mention because according to WHO, the World Health Organization, there's a significant rise in TB diagnosis worldwide. And the highest numbers we're seeing in 2023 since we started monitoring it. Now, it's caused by bacteria, Mycobacterium tuberculosis. The transmission is airborne and it will cause some, again, proteinaceous, dead cell mass. The proteins, your immune system comes into play. And anyway, let's leave that one alone. But usually there's a skin test that you could take, a PPD, but most of us have been vaccinated. Whether or not you believe in vaccinations, I'm not going to go there, but I'm happy to have mine and hopefully would be protected from TB. But the common characteristics that you would see would be chest pain and cough and sputum, and it can lead to chronic scarring in the lungs, as you can see by the image. All right, acute bronchitis we've already just briefly talked about. It typically follows a viral illness, so you should associate it with that. And it's where you have an acute infection or inflammation in the airways or bronchi. It's similar symptoms to pneumonia, but it does not have those chest infiltrates because it's viral. It's a little less damaging. That was kind of my opinion. But all right, let's look at some pulmonary vascular disorders. Embolus, we've already talked about, but when you have think of deep vein DVT, deep vein thrombosis, again, the Virchow's triad, where you have reduced venous flow, have hypercoagulability, and then you have injury to the endothelial wall cells that line the vessel. So think of that, think of DVT, and that makes sense if you look here at this. The emboli arises from the DVT, the thrombus and the thrombosis of the in the deep vein, and it's vein. So veins are taking blood back to the right side of the heart to get reoxygenated in the lungs. That's to go through the lungs, and that's kind of why you would see it in the pulmonary, embolism in the pulmonary system. All right, I'm looking at pulmonary hypertension. You have hypertension, you have arteries that supply your lungs with blood as well. They need to be oxygenated. And so you have some hypertension. It's basically the pulmonary artery pressure goes from about 5 to 10 millimeters of mercury to above 20. It's somewhat idiopathic, but it can be related to a lot of problems. And there would be some edema in the extremities as a result of pulmonary hypertension. Again, it's common with a lot of things, and you would also hypoxemia will also increase the blood pressure in the lungs. Or some cor pulmonale is an interesting one. It's enlargement on the right side of the heart, and it's associated with right-sided heart failure. When you have right-sided heart failure, your edema is going to go into the extremities. Also, pulmonary hypertension is the more common cause associated with cor pulmonale. But when you have this, the basic pathophysiology, you get blocked, the blood is blocked from flowing properly to the lungs, and it can't be, oxygen then can't be delivered. And so what happens is the heart will compensate, and then it thickens the right ventricle, hypertrophy, which kind of then expands the chamber so it can hold more blood, and as it enlarges, the heart starts pumping more efficiently. So it's getting into that cardiomyopathy part, and it works in overtime and eventually failing. So it's this interesting situation with your lungs and your heart, and a right-sided heart failure and pulmonary hypertension. All right, real quickly, some malignancies. Sorry to burn through this quickly. This is some lip malignancies related to the respiratory tract. That don't look good to me. You can also have laryngeal carcinoma of the vocal cords, and more commonly, some lung cancers. Most common cause, obviously, you can see the mass here on this X-ray. Smoking is the biggest issue there. Heavy smokers have a 20 times greater chance of developing lung cancers than non-smokers. This is what my mother died of. She was a heavy smoker. Um, it's hard because we tend to blame smokers, but it's a really bad addiction. We should blame the tobacco companies. My mom started smoking in the 60s without any knowledge of and what it can do to you. And addictions are hard to beat. And it's very addicting. Nicotine is probably I think one of the most addictive drugs. I don't handle it well. I tried smoking just to see what it was like. It made me very sick. It was worse than being drunk. So with my mom's history and a couple episodes of feeling nauseous, I never took to smoking. But it's very related to cancers of the larynx, oral cavities, esophagus, and urinary bladder. Smoking is it's a thing that you should quit. It's got bad associations with about every chronic disease you could think of. But there's also environmental and occupational risks, asbestos and other things. But smoking is what we typically think of. Or just real briefly, there's two types of lung cancer, NSCLC and SCLC, non-small cell lung cancer versus small cell. You want the bigger cells. If you're going to get lung cancer, that would be the better diagnosis. Not small cells, those are a little bit harder to treat, and are usually the outcome is not as good. But lung cancer is a tricky one anyway. So depending, but yeah, there's just two categorizations based on the cells. You can kind of see them here, small cell, and this is non-small cell. That's what it would look like histologically, or under the microscope, a smear. This pie chart sort of shows you the incidences of non-small compared to small cell with the smokers versus non-smokers. And you can see if you're a non-smoker, you have less of a risk of developing some of these cancers. So yeah, just keep that in mind. All right, two more things and we're done. I have videos that I'll let you play, and you should play these because you can, they're I love Nurse Ryan. He does a great job explaining some things, but there's two um, uh, breathing patterns that you should be familiar with. And Kane-Stokes is one that's characterized by apnea. So there's periods where they're not breathing. And then they breathe again. So it's a near death breathing pattern. It's not good. They actually stop for a while. And you think of this with the disruptive apneas where you can see the stop signs down here. It's often observed in patients with congestive heart failure and renal failure and intercranial pressures and things. So the apnea, then what happens is that it leads to CO2's increase, which causes the compensatory hyperventilation. Then you have decrease, which causes of CO2 that causes the apnea, and it recycles. So that's one. It's going to start this video, but we're going to skip it. I'll let you play it. Same with Kussmaul's breathing respirations. It's different. It's more laborious. It's often associated with metabolic acidosis and sometimes kidney failure. It's severe hyperventilation. And what happens with that, it's trying to bring in an O2 to reduce the CO2. So anyway, play those and take a listen to those. And I hope that helps. All right. Thank you.